It is a pleasure to be part of ICF Education Conference in Kuwait and make this remote presentation on defining disability using social participation tools of Quebec model of disability creation process and Washington Group in disability statistics. My name is Turmusani and I specialize in disability inclusive development, that is policy research, strategy development, and capacity building. This short presentation will look at ICF in practice in some selected countries, with a focus on 2 case studies where a variation of ICF tools was used to identify school-age children with disabilities. We will look at the slides right now. So the key points here is that definitions have political implications. Definitions are important. They help determine those belonging to certain communities and consequently who is entitled to services and to rights. The social model looks at disability as a socio-political construct in the sense that the way we define disability will influence measures put forward to dealing with it. Therefore, when disability is considered socially constructed and culturally produced, the solution is put forward in removing disabling barriers and discrimination. There are different strategies for the identification and reaching out of children with disabilities, and this includes screening, orientation, and referrals to different services and medical consultation. In a sense, to diagnose a person with disability, one needs to be screened, identified, and classified. This could be a complex process when tools and trained personnel are limited. Tools used in this research can greatly help in this regard. This work is based on research and consultation in a number of countries using a variation of WHO ICF in defining disability among school-age children. This includes tools developed by tools based on Quebec model of disability creation process of social participation developed by International Network of Disability Creation Process. It's referred to as a RIP. This is a Center of Excellence based in Quebec, Canada, and Washington Group in Disability Statistics. Participating country research was conducted in Togo and Myanmar, and consultations conducted in Iraq and Bangladesh. We will look at 2 case studies, as I mentioned, the first one on Togo. The project objective was to improve the quality of life of children with disabilities, especially girls, through strengthening the right to protection. This is part of Plan Togo, Finland, to support the baseline study and the research under their community-based rehabilitation. Specific objectives included also improve public perception towards the right of children with disability, improve access to services like healthcare, rehabilitation, education, vocational training, and social protection, reinforcing capacity of local NGO, DPOs, that is Organization of Persons with Disabilities involved in CBR, advocating the rights of children with disability for protection before duty bearers. To accomplish this, a participatory research was conducted in the middle region of Togo in 32 local communities and was carried out by a team of 16 people, including 8 data collectors. Data collected from 1,684 persons, half of which are children, through standardized questionnaires, focus group discussion, and key informant interviews. Analysis included statistical SPSS and qualitative thematic interpretation. Before we discuss the tools, it's argued that the rights related to protection of children are best fulfilled through the exercise of activities necessary for daily living, that is, life habits, such as eating, personal care, and mobility. This study takes note of the actual situation of children with disability, personal factors, environmental factors, and life habits, and how they are interacted and fulfilled in the context of Togo. 2 sets of tools were used in this research for data collection. They are life habits assessment tools, that is the life habit assessment questionnaires, which measures routine daily life activities such as eating or personal care. It is divided into 12 categories, including nutrition, personal care, mobility, communication, housing, community life, education, employment, and recreation. Each category has a number of life habits depending on age group. There are 2 questionnaires for each life habit. The first determines level of accomplishment and type of assistance required, and the second question determines level of satisfaction. The total scores of applicable life habits for each category is then calculated according to a formula to establish a score and subsequently the personal profile. The second tool used was the measure of the quality of the environment, which assesses contextual barriers such as outdoor mobility, attitudes and opportunities, and their influence on the accomplishment of life habits. It's divided into 18 categories, including social network and people's attitude, labor market and income, judicial services, socio-sanitary services, education, public infrastructure, technology, technical aid, political system, and social rule. This tool is directed to the age of 14 to 18 years old. Each category has a number of factors to evaluate their influence on accomplishment of life habits. Factors or situations can be either facilitating or obstructing the fulfillment of life habit. The respondents are asked to identify the kind of influence, whether it is positive or negative, this factor can exert on their life habits. The last point in this slide is the community-based rehabilitation, which is a strategy for community development focusing on rehabilitation, equal opportunities, and inclusion of persons with disability. The key issue in CBR are awareness raising to overcome attitudinal barriers, capacity building of local community, and participation and referral services. All are aiming at inclusive development. According to CBR matrix of WHO, there are 5 components that work together under this strategy. These are inclusive education, livelihood, health, social, and empowerment. Examples of interplay between components may include how health component, that could be assistive technology, assistive devices, contributes to the rehabilitation and preparedness of children with disability to receive effective education, or how the empowerment component helps in raising awareness and advocacy on the rights of children with disability to inclusive living. So after conducting the research, we came up with a profile of social participation of children with disability in Togo. In this slide, we see 2 charts. The one on the left, that is list of life habits of children with disabilities, and on the right side, the environmental barriers. So briefly, life habits, the most accomplished life habits were related to survival. Eating, personal care, and housing. Least accomplished life habits were related to social role and responsibility, such as work, and to a certain extent, education and mobility. For community living, the single most affected life habit was that of communication, especially for children with hearing impairments. The environmental barriers that limit the inclusion and protection of rights were related to accessibility and reasonable accommodation, such as barriers pertaining to independent life, like access to work and source of income, barriers related to physical accessibility, like inaccessible public infrastructure, roads and transport, barriers related to access to services, healthcare, assistive technology, lack of communication technology, and accessible information among the population of children with disability. What we can conclude from this research and lessons learned and recommendation is that there were some challenges in the identification of children with disability at the local level, and therefore capacity building is needed, including training on disability definitions and disability creation process under CBR approach, with the recommendation to move beyond concepts of promotion and prevention into activities of protection and reclamation of rights. However, the role of prevention remains important in detecting and stopping abuse from happening. In particular, developing a comprehensive approach to disability rights, child right protection, with a strategy focusing on prevention, mitigation, rehabilitation, and inclusion, equally reinforcing synergy between different components of CBR, community-based rehabilitation, and developing flexible system of indicators quantitative and qualitative. The second case study is from Myanmar. This is situational analysis of children with disabilities in Myanmar with focus on protection and education. It's conducted under IPA Global and UNICEF in collaboration with Department of Social Welfare. Project has two main objectives. Objective 1 assesses the quality of social services received, such as education, health, and social welfare, the extent of participation and inclusion of children with disability in local community, existing provision of community-based rehabilitation services and possibility for scaling up the system, and existing procedures for identification of disabilities and referral to health services. The situational analysis, we refer to it as CTAN, provides an in-depth analysis of barriers affecting the full social inclusion of children with disabilities, focusing on 4 determinants of inclusion. These are enabling environments, supply side, demand side, and issues related to quality of services. The second objective aims at estimating the prevalence of disability among children in 3 educational focused townships with a sample of 3,768 based on a household survey, excuse me, utilizing the Washington Group module for measuring child functioning and disability. And also this objective aims at mapping stakeholder services targeting children with disability. Stakeholder mapping includes children with and without disabilities, their families, service providers, local DPOs, policymakers, and other development partners. The CTAN instruments, to fulfill the CTAN, a survey was developed based on Washington Group disability statistics, as well as other tools such as checklist interviews, focus group discussion, and key informant interviews. The Washington Group approach to disability measurement identifies basic activities or functioning domains where respondents may experience difficulty functioning in their environment. For child functioning module under this CTAN, the following domains were developed: seeing, hearing, mobility, communication, comprehension, learning, relationship, and playing. Questions also covered emotions, behavior, attention, and coping with change. Implications. Having a universal framework such as ICF is important as it provides standards and competence in defining disabilities. However, there are variations of ICF that are taking grounds in generating evidence-based knowledge, such as those mentioned earlier, and we are trying to promote these as well. It is hoped that improving identification practices will help improve inclusion outcomes for children with disability, fulfill CRPD rights, and achieve SDGs. Simply, when we identify the child with disability, whether for education or healthcare, it means they will receive the services, the right will be respected, and development will take place. Issues encountered, challenges to the research and the consultation. Some of them are common, and some of them are particular to this research. There was a need for training of data collectors. There were 2 kinds of training needs identified. That is disability awareness training, such as disability equality training, resource mobilization, advocacy, and data management, especially in the local community under the community-based rehabilitation approach. There were also training needed for instrument-specific, how to use it, how to use research tools for collecting data, how to use the social participation tools, the life habit and quality of environment, as well as Washington Group on disability statistics. There were also issues related to data coding and data entry, particularly for statistical analysis, some logistics in the rural area, such as transport and security, and user participation. People with disabilities did participate in this research, on these research, rather actively. However, maybe this can also be improved in the future. what we can conclude from this presentation is that in the context of disability, the lack of opportunity to perform life habits, life activities leads to exclusions from the mainstream and significantly limit the social participation. The environmental barrier in place add another obstacle to the disabling experience of people with disabilities, including children with disabilities. This conceptual framework of social participation can be useful in understanding the dynamics pertaining to social exclusion for people with disabilities and can be used also in measuring and researching inclusion and empowerment issues. Both instruments used in this research, life habits, quality of environment, as well as the Washington Group, takes note of this important issue under ICF framework. Washington Group in disability statistics has become widely known worldwide. It provides a simple and practical way of identifying disabilities based on self-identification approach. For deeper insight into life habits and environmental barriers, social participation tools can be used. However, both tools can be used hand in hand for a comprehensive and effective identification, screening, and classification of disabilities. Thank you for participation. This is the end of the presentation.